Okay, broadcasting. Hi, everyone. We're here today to talk to you about a topic that probably doesn't get discussed as much as it should be and is really close to your hearts and ours. So we are really excited to be able to offer you some experts today that can talk about basically the trauma that's associated with just having infertility, with losses of infertility, whether that's a failed cycle or failed cycles, with pregnancy losses, and you know, what to do if a cycle or any of the cycles don't work out, kind of how to handle that situation and everything in between. And so, where's my next slide? So when you go, please feel free. We want this to be interactive. We're so grateful that we got a couple of questions so far, and we'll try to address anything we can, except for very specific medical advice. But any general questions, please make sure in the chat that you change it to all attendees and presenters, or else only we would see your question. So go ahead and maybe do that now and put who you are and where you're from in the chat, and we'll keep an eye on that. But we do hope for it to be interactive. We have your questions in advance, but feel free to ask us any questions. This is a safe sharing place, but we are recording. And so this recording will be available for a few days after the talk, but just so that you're recorded, if your name is in there and you want to remain anonymous, you can change your name in your own Zoom to just your first name or make it anonymous. So we're going to we'll introduce ourselves in order. I'll just start because I'm already talking, and my name is Monica Moore. I'm a nurse practitioner in the States. Dr. Nikopoulos, who's the first one here, is going to try to hop on and join us if he can, but he's just not sure that it's going to work out today, so we'll grab him if we can. Dr. Chen is joining us after technical difficulties.
Yes.
You should be on any second. And
oh, wait, can you see?
Oh, you're on?
I'm here now.
Oh, I see you. I'm sorry, you're not in my little 4 people thing.
Okay.
So, yay, okay. Can you introduce yourself, Dr. Chen?
So my name is Serena Chen, and I am so happy to see everybody here. My little logo is at the bottom there. I'm from the Institute for Reproductive Medicine and Science at St. Barnabas. And can you guys hear me? Because I'm using a new microphone, and that might have caused some of my technical issues because my computer just died right in the middle. But so I'm in New Jersey, I'm in the States, and I love this group. We've been doing a bunch of these. So if you guys haven't seen the other talks, they're all recorded, and they're definitely worth going back to IVF Babble, because we really do a deep dive into all our topics, and I always learn something. So I think you will too. I'm just really happy to be here. So I make test tube babies in New Jersey, basically.
Thank you, Dr. Chen. Dr. Braverman, can you introduce yourself?
I'd be happy to. I'm Andrea Braverman. I'm a clinical health psychologist at Thomas Jefferson University in the Department of OBGYN in Philadelphia, Pennsylvania. And I've been in the field working in infertility, women's health, all of that since for a long time, since the mid-'80s. And this topic is definitely near and dear to my heart. It is something I work with folks every day, and it is such a complicated emotional journey to begin with, and then throwing on the repeated failures and miscarriages is just so much on top of what is already so much. So thank you for having me here today.
Thank you, Dr. Braverman. And Sarah and Tracey?
Yeah, hello, I'm Sarah. I'm one half of IVF Babble, and I've been through fertility treatment. Mine was a long time ago now, but it was 4 years of failure, and 4 years of dealing with the trauma of failure. And my biggest regret is never talking to somebody like Andrea. So I buried so much heartache, so much pain, to the point that I think it's still inside me. I still think that trauma is deep inside, because I still have, even though my fertility treatment, thank God, worked out, I still have pangs of, it's so weird, but I still have pangs of jealousy when I hear other people that have got pregnant naturally. So all that trauma that I experienced, I think it's buried in here deep. So I'm fascinated to hear about ways that people can sort of regain that strength and that control, so that I can then pass that on to others. But T, I know this is a very poignant topic for Tracey.
It is, and actually I'm getting quite emotional about it. Yeah, my journey was 10 years, and the beginning of the journey, I had an ectopic, and it was when I had the ectopic I suddenly thought, actually, I really want to have children. I didn't realise I was 38, 39. It's like, oh gosh, I've got to get with it. But basically, on from that, I had one IVF that didn't work. And the next day I was back at work and it didn't work and I blocked it. Then I had 5 miscarriages, and each one I sort of blocked. And at the time, I think the reason for doing that was because my mum and dad were both ill at the time. And it was sort of one thing too much to be able to have to take that on board. But then after, it was about sort of 9-10 years, I ended up having my beautiful twins, which was on my second IVF. But also just a heads up that in order to get to that place, I had to see the right consultants, who then found out that I had endometriosis, a blocked tube, a polyp, a thyroid problem, and my husband also had some issues. So once they were sorted out, we had 2 eggs put back in and it worked, and I had my miraculous twins. But what I wanted to say was I didn't have someone like Andrea there, and I didn't open up to anyone, not even my husband. And basically, I'm so sorry. But basically,
it's such an emotionally charged subject for everybody. It's so emotionally charged. And the other thing is that I feel like the definition of femininity, there's a social construct that is associated with being a mom and the ability to do that. So there's so many different facets to this, that helplessness, you know, the lacking, the stuff that you described, and then how we might be perceived or have perceived ourselves because of these social norms that we may not feel like we fit into.
But Monica, what I wanted to sort of go on to say is, number one, I didn't think I'd feel this emotional talking right now. So it just proves that things are very deep. Yeah. But secondly, that actually I was on a train and going into London to a meeting, and I just happened to look on my phone and I saw this image, and it was an image of a woman that was sort of kneeling down, and she had a baby, but not a baby, sort of 2-year-old, say, just with her hand on her shoulder. And for some reason, it was as though someone put the pin in the balloon and it just popped. And I literally, goodness knows what people thought on the train, because I just could not stop crying. And I got to the other end and I sort of phoned my husband and I said, I can't believe I've just cried my way all the way to London by seeing this image. And yet I thought I was okay. And the thing that he said was, do you know, I always wanted to talk to you about things, but it was difficult to get in to actually access how you were feeling. He said, I was dying inside thinking, oh no, we've lost another child. But actually you were just like, don't worry, it's fine, let's move on. And he said, no, all I wanted to do was support you. So I think that it's incredibly important along the journey where things like this that might happen to actually consult someone like Andrea.
Well,
Thank you for sharing. That's hard to talk about. Sorry, Dr. Braven, what were you going to say?
No, I was just going to say, Tracey, I think you highlight just how complicated this all is, and that things change, and how we cope is not, you know, it changes throughout the journey. And, you know, what you needed to do to keep going was to say, nope, I'm going to focus on what I have to do. And I think many of us have had the experience. It's only until we're sort of through the event that afterwards it's like, oh, now I can make room for the feelings. But meanwhile, you know, we can also have partners that are in a very different place. And, you know, so there, it always feels like a three-ring circus going through this, and depends which ring you're looking at as to what's going on and whether you're attending to yourself or to others. I mean, I've been, when I used to work in a clinic, I was always amazed when somebody would walk in the door, not surprised, but amazed. Somebody who had been, resolved their fertility and had a child, and they'll walk in, they'll take one look at the waiting room and burst into tears because it is just so evocative. Thank you for sharing your journey. I know it helps break that isolation.
It does. Thank you.
So I mentioned before that there's so many, I think a lot of us as a kid, when we had a dream of our future, it included being a mother. It just seemed like this is a natural step. I remember doing these like little games where I'm going to live in a house with 2 floors and 4 bedrooms and be a mom and have this many kids and this many dogs and cats. And so not only are we, when infertility strikes, do we feel like this is sort of grieving of a childhood dream in addition to grieving of all these other things. And so it seems like it's just so deep rooted and emotionally charged. So when these are reader questions. And so when someone realizes they're not going to be a mother, how do you come to terms with this? I think we talked about compartmentalizing a little bit, if that's the word that Tracey was describing, Dr. Braverman was describing, but either Sarah and Tracey, your perspective, or Dr. Braverman, your patient's perspective, how can we come to terms with this?
I mean, I'll just, from my perspective, I don't think I'm not sure that you ever come to terms with it. I mean, it's decisions along the way, which is, look, we can always choose to be a mother. It just may be along a different path, and that path may be different. Look, I've had some people who say, I won't go see the doctor at all, and I'm only going to come, that's my journey. And other people who say I would never adopt or do donor or use a surrogate. So I think the coming to terms with it is, working through what is it that it means to be, to be a parent, and what are my choices? And I think along that is a lot of grief work. If that pathway is closed to you and others are not open, there's no way not to grieve it. And then there's all the mini grieving of, think about it. We let go of it. Originally, I think most of our dreams are, if I'm going to get pregnant, I'm going to make mad, passionate, beautiful love with my partner, and then sort of wake up pregnant, and that's sort of this will be, as patient said to me yesterday, he said this was going to be the realization of our love and the culmination of it. So the first time you go to the doctor, you give that up a little bit. All right, so the doctor will help us a little bit, no big deal. And then, each step along the journey is another thing that we give up. So there's all these little grieving. And if we get up to the point where we've had unsuccessful cycles or miscarriages or losses, then it becomes a different type of grief. The grief of saying, this is not going to be a part of my life, if you're choosing not to explore any other pathways. And that is, there's no way around that grieving process, or sorry, process.
Yeah. And so, by the way, I had to change all the S's to Z's because you guys write S's and we write Z's. So anyway, because it made my spell check off.
I was just going to say,
yeah.
Monica, that point there, when you realize you may not be a mother, how do you come to terms with this? One of the most powerful posts that we did on Instagram once was a quote from one of our readers who had said, what is the point in living if I can't become a mother? And the response to that post, it is phenomenal how many women actually feel that way. It's overwhelming to see how many. And the only comfort that came from seeing all those posts was the comfort of how many of us have all thought that same thing. Because when you're going through it, you think you're the only person in the world. You think you're the only woman that feels like that. So when you understand that actually this is a common thought, there is some, even though it's tiny, there is some comfort to gain from that. So that's the only thing I would say. But Monica, there's a question in the chat. You told me to keep an eye on.
Yes, so there's the Q&A one is similar to one we have on the next slide. Dr.
Okay.
Thank you so much. And so let's try to address that when we do that. Thanks for keeping an eye on that, because I'm unable to because of the advancing of the slides. Dr. Chen, assuming we're willing to go all the routes that Dr. Braverman just briefly outlined, donor, IVF, what is our chance that one of these options will quote unquote work?
So despite all the pain and suffering that people go through with infertility treatment, from a physician's perspective and a scientific medical perspective, the sky is very blue. The overall prognosis for success with current technologies is quite high. And, but that's a big caveat, overall success. So overall success often can mean a long journey. Some people do get pregnant with their first IUI, or they walk into the door and I put the sonogram in and whoa, they're pregnant. But most people go through an evaluation and have to try multiple times. Even people where I feel like I don't know why they're not getting pregnant, they're young, they're healthy, everything looks really good, overall prognosis is good, they all end up getting pregnant, but sometimes it takes a while, multiple cycles of IUI, multiple cycles of IVF, even for young, healthy people. And if you have other challenges like with age, like being over 40 or really diminished ovarian reserve or severe endometriosis, things like that, that can be really challenging. It can take more treatment. Also, my arsenal includes many treatments, and you alluded to this before, many treatments that may not really be acceptable to people for whatever reason, personal reasons, financial reasons, religious reasons, philosophical reasons, just lack of comfort. Not everybody can handle going through IVF cycle or wants to go through an IVF cycle. A lot of people do not feel comfortable with donor sperm or donor eggs or a carrier, a gestational surrogate. Those are all the tools in my toolbox. If I can use all the tools in my toolbox, I can basically get anybody pregnant, but that may not be your journey. But in general, if you're willing to do some treatment and kind of keep your head in the game, both mentally and physically, mental and physical health, vast majority of the time, you will have success. So what we're finding in the developed world is that all these treatments are available. A lot of people have some coverage or some means to access them. And we're finding one of the biggest barriers to be up here, the mental and emotional barriers, because people just often lose hope. And when they lose hope, then your mental health and your physical health often will decline and people drop out. So we have a really big issue in the United States with dropout, because we have terrible insurance, and even when people don't really have financial barriers, when they're being told, well, this is just going to be really difficult, or people are acting negative around them, or they have to bear this burden all by themselves without help. A lot of people that I feel have really good chance of success will often drop out before they get to the baby. And I feel like that's a big message I want everybody to take home, is that often from a medical perspective, there often is more hope than it feels like there is. Because when you're suffering from infertility, that can feel very dark and very negative and very heavy and often very hopeless. And yet, when you look at it from the doctor perspective, I'm often like, I don't understand. You have such a great chance. Please come back. Please come back and see me. And my patient is you know, suffering at home and really sad. So how can we overcome that? And maybe Dr. Braverman, from my perspective, how can I do a better job of helping my patients keep their heads in the game and helping them to be hopeful without being, you know, annoying or Pollyannish, because that's not really helpful either.
No, that is fair. It's, you know, to me, when I work with people, I say, do you envision this as a 50-yard dash or as a marathon? You know, and because you run it differently, and so, you know, trying not to lose hope, and it's hard not to, because every month there is that roller coaster, right? We've got the 2 weeks where, you know, we're gearing up, and it's almost like, you know, when you're getting ready to ovulate, it's like there's something to do. We can focus. There's, you know, even if it's just timed intercourse, it's like, darn it, I'm gonna make sure that I'm timing this right. If you're taking medications, I'm taking my medication. Or if I'm going in for monitoring, I get feedback. And then, you know, then there is the insemination. There's the you know, the timed intercourse, there's the IVF retrieval, whatever it might be. And then we're into the 2 weeks waiting, the very, very infamous 2 weeks waiting, which, you know, most people say for the first couple of days, I got this, I'm okay. You know, now we're just sort of, but then that quickly wears off, right? And then it's like, what do you think? And then we're in our bodies 24/7. And so, you know, I don't even want to go to the bathroom, because God forbid if I wipe and I see blood, then the everything, you know, is dashed, and, you know, I lose hope, and then I have to build myself up, because maybe that's implantation, maybe it's not my period, but I feel crampy, and it's exhausting. And I think this is one of the major differences that we see between women and men going through this, is that it is not to say it's a contest, but for women, it is exhausting being in your body 24/7, which then connects, unfortunately, at that point to our brains, which then keeps us very, very busy, which then bounces back to our hearts, which can be heavy or hopeful. I mean, and so, you know, it goes round and round. And this is why we see the dropout, is that people, you know, when you factor out financial costs, it's the number one reason is the emotional burden of all of this. So how do you keep going? It's, you know, part of my favorite question that I teach patients. So now none of you have to come see me. It's a simple question, you know, is this fact or is this fiction? You know, what am I telling myself? Is this from facts? Is this because Dr. Chin, when I had my consult, said, oh, Andrea, I'm so sorry, your ovaries fell out, you have 0 chance of getting pregnant? Or is it that, you know, and I'm just not, so that is a fact. You know, my chances of conceiving now are nil. Or is it more of a fiction that I've gone through, you know, we've all done that. I've tried to conceive, you know, either on my own naturally, with no cast of thousands around me, or I've already done IUIs, I've done IVFs, nothing's working. Why would this work again? And, you know, I'm just losing hope. And so therefore, you know, and this is what I always love when people fail their first IVF and they say, well, it's not going to work for me. And I said, is this a fact? And they're like, well, yeah, because if it would have worked, it would have worked already, right? And that's different from that, but that's a fear. That's not a fact. I'm scared to death because if this didn't work, why would it work the next time? And so trying to pull apart what is fact, what is fear. Fact is, I'm having fertility difficulties. The fear is it will never work. So how do you keep going? To do, you know, you keep trying to stay on top of. Part of it is, what are we telling ourselves, you know, and what are people asking of us? So anyway, I'm sorry, I'm rattling on way too long, but, you know, I think some of it is also having to just realize, you know, what do you need? Do you need people who are your cheerleaders, who take out their pom-poms and, you know, are going rah rah because you can't do it for yourself? Do you need people to stop telling you that, you know, it's all going to work out, because you need to be able to contemplate what if it doesn't? We're all in different places.
It's so hard to maintain that balance because what I would love to see is people be able to be hopeful and positive about their current cycle, but be prepared for that current cycle not to succeed. Because I know their cumulative pregnancy rate, overall pregnancy rate is close to 100%, and yet the per cycle pregnancy rate typically for IVF is 50%, and for IUI significantly lower than that. But you know, if you take 100 people doing IVF and they have a 50% pregnancy rate, then 50 of them will be pregnant after one cycle. After 2 tries, 75 will be pregnant after 3 tries, 87 and a half will be pregnant, and so on and so forth. And that is how I explain the numbers. I also think we have a huge issue in women's health and reproductive medicine that we do not have answers. And when people don't have explanations, it's harder for them to digest. Like, why am I failing? The embryos look so good. Why? And I try to explain, you know, Mother Nature is very inefficient. There's nothing wrong with you. You made these gorgeous embryos. Now that I see these gorgeous embryos, I know eventually something's going to be normal. So let's just keep trying. Now, you know, having said that, that may not necessarily be the case if you're using your own eggs and you're 44. That's a very tough situation that might require egg donation. But we have so few answers. We have a lot of technology. The technology really works. I know the statistics and I know they're good, and they're good for most people. But do I know the why? No. You, I think, will get the baby. I don't know that you're going to know the answer to the why. Like right now, too little money, too little attention to women's health. We're working on changing that. Right now we can get you the baby, but the answer is going to have to wait.
We have a couple of questions in the Q&A, and one of them, which is actually two of them actually are kind of we're talking about now. So one is in terms of what would the reasons for a reason that IVF would fail. So if you could, Dr. Chen, address.
Number one, genetics. Now, if you had an embryologist.
But genetics, excuse me, of the baby, not necessarily of the mom and dad, right?
Right. The vast majority of abnormal embryos that fail to implant or result in a miscarriage come from completely genetically normal parents, because the making of the embryo, the fertilization process, getting the right number of chromosomes into that little tiny embryo is extremely complicated. We don't understand it well. And Mother Nature, you know, half the time it just doesn't work. Even in a young person, half the time the number of chromosomes is wrong and the embryo does not implant, or implants and then fails later, resulting in a miscarriage. So the number one thing is the genetics of the embryo. Now, there's a lot of attention right now about the lining and the genetics of the lining. I think that's less important, but that, you know, the lining can make a difference. Your overall general health can make a difference. Generalized medical conditions can make a difference. Somebody did ask about autoimmune. Autoimmune is extremely controversial, and we know in mice that there can be very defined autoimmune conditions where you have a completely normal embryo and it just falls off the lining. It just doesn't stick. That does not really occur in humans. So the whole autoimmune factor thing is a lot less well understood in humans. And most autoimmune treatments don't hold a lot of water. So for miscarriage, the only autoimmune treatment that really is recognized by medical societies is antiphospholipid syndrome, which is a form of lupus. All the other things, and there are Dr. Google and others, there's a lot of autoimmune stuff online, and people with a history of miscarriage often can end up undergoing dangerous, unproven, and expensive treatments because you're desperate, and you would do anything to have a baby, and that industry preys upon that. So we worry about that. You know, if Dr. James was here, I'm sure he would agree with me on this. Please make sure you see a really good specialist, and IVF Babble can help you find somebody reputable and reliable who is going to tell you the truth about, you know, does autoimmune in your case make a difference? So I didn't see any other. Monica, what?
There's only another, well, there's two new questions, and
Okay.
I don't want to, we can briefly answer them here, but I do want to tell you that these were our talk last week, our webinar last week talked about unexplained infertility a lot.
Yes.
Which is one of the questions. So I would refer you also to that talk because we have some slides with pictures.
We had a great, that was a great session, and we didn't have that many people in that session. That's definitely worth going back to.
So there was a unexplained infertility. So I'd love to refer you to that, but happy to answer a question on that privately. And there's another question about septum and if it could cause IVF failure if not removed. And my understanding of the septum is it's more
a miscarriage issue or a growth of the baby issue, but seems to be less related to implantation failure.
So we have a lot of questions here about anxiety and either due to multiple failed cycles or between a fresh and frozen transfer. And so Dr. Braverman, you know, so the issue with infertility is you don't know if you're going to have infertility until you try to get pregnant. And you can't try to get pregnant until you're ready to be pregnant. It's like we could do a test drive and be like, does this work? Great, it works, you know, and so, but we're not ready. We have to wait till we're ready. And when we're ready, the time differs and we may be older, et cetera. So there could be a lot of anxiety. First of all, should I have tried when I was younger? Why did I do birth control pills for all these years, even though that was the right decision for you at the time? But there's then also just anxiety. And now some of our forms of stress release, maybe a glass of wine, maybe vigorous exercise, we take away from you because you're trying to conceive. So now we have the seesaw of even more of a stressor, and we take away some of the empowering coping mechanisms. So how do we deal with this anxiety? And then I want to talk about how we deal with others in the midst of it.
Sure. Yeah, not only do we take away usually our favorite mechanisms for coping with anxiety, but then we've also added COVID. So that also just compounds it more. So going out and like get a massage. Oh, right. Can't do that. You know, go out and have dinner with friends. Oh, right. Can't do that. So, you know, there's just I think normally what we can do and what we're doing now, I'll separate, and we're talking now. So let's talk about what we can do now. You know, some things haven't gone away. One is sort of saying, tuning in and even listening to what are your anxiety thoughts. You know, most people say I'm anxious, and I'll say, okay, great. What does that mean to you? And for lots of people, it means different things. For some of it is just that anxiety about feeling like everything is out of control. I mean, that is one of the bumper stickers of going through fertility, is just feeling like everything's out of control. So what are things that, you know, you can remind frame so that, and remind yourself that there is some control, choices around making cycles, planning, you know, even for some people being able to say, I'll be able to say enough's enough if it feels too much. For people who already have anxiety to begin with, and that's a lot of people out there, that this just only feeds into that anxiety, that worrying, that constant having your brain going. So what can you do about it? You know, for those of you who've been in therapy, you may already know some of these techniques. Just even if you can't do vigorous exercise, there is no reason why you can't, with somebody who knows what they're doing, still do, you know, gentle yoga, doing things to help clear your mind and still take care of your body. There is no reason why you can't journal. Nobody has yet said that that is contraindicated with any cycle. So writing it down, you know, not just being stuck in the thoughts that go round and round faster and faster. Because if we were doing sort of a free association to the word anxiety, I mean, it would be kind of a fun thing to do in the chat. What's the word that pops into your head? And when I've done this with crowds, for some, you know, it's fast. Everything's happening too fast. I can't slow it down. That's my dog barking in the background. Let's not forget pet therapy. You You know, it's another thing to get you out of your head and into and doing something else. Sometimes if you have if you have a pet, reaching out and saying, let me get out of my own head and connect with a nice living creature. My dog's pretty soft, so it's nice to pet him. And for others, there's a reason why I think so many people will get pets or additional pets. A couple I was working with 2 days ago said to me, every time we got a failed cycle, we were getting a cat. We had to sort of put a limit on that. We have 3 cats already. So, let's keep this within reason. But, what is it that helps you? Is it talking to your partner? Is it talking to a loved one, a friend, a family member? Are you a talker? Are you not? If you're not a talker, then how do you talk to yourself? Is it written? Is it by using art? I mean, so many of the people that I know that are artists will go to their expression. There was a wonderful woman, I believe from Mexico, who published a small book of all the paintings she did for going through her fertility journey. And it was all pictures of empty chairs, because that's what resonated with her. So, there are still things available, even if you're not exercising heavily. For where I live, we have to be masked when we go out, but there is still pleasure in taking a walk in the city, around the neighborhood. I'm fortunate in that where I live, it's very green. It is going out and saying, I'm going to pay attention, and when the sun sets, watching the sunset. Anybody who has been at my house around the early evening hours always knows that the way the light hits the trees, that I stop and actually pay attention to that and try to get out of my head for a few minutes, but it's hard work. So those are just a few, but if nothing else, if use the chat to put in there what has been helpful for you, and maybe you get an idea from somebody else. That's why these coming together are so powerful.
Sorry, I just want to say, Sarah and Tracy, can you put the link? We've had a couple of questions about the link for the previous webinars. So with the one on last week, and then we did one on self-care that talks a lot about this as well. Could we put a link, or is there a place that people should go for that? And I'm sorry to interrupt.
Yes, no, yeah, we'll sort those things out. But I just wanted to pick up on something Andrea said there about sketching your emotions. And there is an incredible Instagram account that I would recommend everyone to follow. And it's called Infertility Illustrated. And it's a lovely, lovely friend of ours. She lives in Chicago, and she used her account to express the way she was feeling. And so many of her illustrations helped me. Even though, again, my journey was a long time ago, but as I was looking through her drawings, I just connected with so many of them. And again, it's that feeling of, oh my God, that is exactly how I feel. And seeing that in her illustration not only made me think, oh my gosh, those were the feelings I was having. And then again, it goes back to, she felt that too. And so again, it was that lovely connection, and it picked me up. And even though some of the images are quite raw, they're exactly what you need to see sometimes, because it just gives you that feeling, that comfort. Yeah, Infertility Illustrated. It's a great account.
I know that account. It is really good. So there's Dr. Chen, there's a couple questions in the Q&A that are medical questions. I wonder if on a hydrosalpinx and something, arcuate uterus, I wondered if we could.
Okay. So I think arcuate uterus is actually normal, but arcuate uterus is often something that they say on an HSG or a hysterosalpingogram. That's the dye test, where they put a little metal clip on your cervix and they put in dye, and then they take x-ray pictures. And the x-ray pictures are a great way to figure out whether your tubes are open or not. And they give you a general idea of the uterus, but they're only looking at the cavity. It's really helpful to follow that test up with a saline hysterosonogram, and very, very helpful to follow it up with a saline hysterosonogram by a reproductive specialist as opposed to a radiologist, because then we get to put all that information together and we can say what it means and is it important or not. Sometimes people have an arcuate uterus because they got a big fibroid at the top. You would never see that on an HSG or hysterosalpingogram. But the most common finding is arcuate uterus is normal. It just means instead of having a flat top, you have like a little dip, like a little bit more of a heart shape. And that can be that most of the time that's a completely normal variant. Now in somebody who has multiple miscarriages, we often look at arcuate uterus much more closely and wonder, could that be a small septum? And then you need to do follow-up studies. You need to maybe do a saline sonogram. Maybe you need to have a hysteroscopy where you put a little telescope while you're asleep in the OR under anesthesia, and you put in a telescope, and then you maybe shave down the arcuate part and see, is it muscle, which is normal, or is it fibrous tissue, which could possibly increase the risk for miscarriage. Sometimes it can be really hard to tell. And somebody with just infertility and no history of miscarriage at all, you do a saline sonogram, you can probably just say, oh, it's just a normal variant, let's just keep an eye on it. But somebody with multiple miscarriages, I would probably be more aggressive about following it up and addressing it. MRI, pelvic MRI, can also be very helpful in delineating things. But all of these studies really need to be read in the context of having a specialist who treats infertility and recurrent miscarriage or miscarriage. Don't just take the words on the piece of paper. That's not enough. The radiologist is not a gynecologist, and they have a very different perspective. So you must put it into the right context, and you have to have somebody who's actually who knows you and can put the whole picture together, the pictures plus the words plus the patient.
Yeah, and our last week talk, we had that too. So there's pictures of hysterosalpingograms, picture of a hydrosalpinx. We discussed kind of what it's like to have the testing and the diagnostics done, just as a review in case you actually want to see images.
I don't know, Tracy and Sarah, can you get these things onto Netflix? Maybe that would be even better. What do you think?
I know, right?
The Vagina Chronicles, right?
Yeah,
okay.
We're on it.
Okay, cool. What was the other medical question, Monica?
The hydrosalpinx, but maybe that could be just addressed to, because it seems like a specific situation. I wonder if you could type back in the Q&A for the hydrosalpinx under the Q&A one.
Okay.
Dr. Braven, what about the well-meaning friends and family members? So the mother-in-law who's like, what are you guys doing? Why does it take so long? You know, or just the friends that are just enjoying their own life but seem to get pregnant, you know, every time they try. How do we deal with these? And maybe can you give us a couple examples of boundaries that we can use with well-meaning friends and family members?
Oh, absolutely. You know, look, it's complicated. People continue to live their lives. Excuse me, life doesn't go on hold. So people continue to get pregnant, and you know, that also is a marker of time for us, because it's, you know, so many people have friends or family members that are if you've had a miscarriage or due around the same time, it is, you know, it can be extremely painful and, you know, and ongoing. It's not just that initial loss, but then the ongoing. I think that there are a number of things that you can do to advocate for yourself. One is, most people don't know what to do. You know, they mean well, you know, and yet they can really fail miserably in the process. So don't be shy about letting people know what is helpful to you, and also recognize, like we were talking about before, that what's helpful can change. Maybe at one point you want to talk to somebody, but if your best friend is pregnant, and as much as you love her, she may be the worst person in the world to be able to talk with this about. You know, if I can't see her getting visibly pregnant, it just stirs me up too much. And so she's on that other side of the line. She crossed over. Other people say, no, I can tolerate that. So you don't have to kick somebody out of your life, but you also are perfectly entitled to take care of yourself too, and trying to let people know in and let them know what it's like for you, because if you've never been through it, it's sort of hard to imagine. And people will try to say, you know, don't be negative, be positive, you know, you shouldn't shy away from these things, missing the part that we were talking about earlier in the hour, which is I am full of fear that this will never happen for me. So all I do is when I see you, think about what might never happen for me, not this is going to happen for me the way you say it. So again, educating people. Don't assume that they will know, and you offer them that opportunity to learn. Not everybody will take you up on it, and sometimes people disappoint us, and then we are dealing with not only sometimes the intrusive or insensitive remarks, but also our disappointment in people. But then we have to figure out how to keep them in our lives, and understanding some people can be terrific in some parts of our lives, and maybe this is a part that they can't be. And then not keep going back to them looking for something they just can't deliver. You know, one of my favorite remarks by a mom to her daughter was when the daughter finally shared her infertility with her was, I don't understand. I never had a problem getting pregnant. Needless to say, that was not the helpful, supportive remark she was looking for. But you know, people, it resonates in different ways. If your best friend gets pregnant and you don't, she's feeling guilty. She's feeling uncomfortable. She wants to celebrate her pregnancy. She doesn't know how to do. You know, people are. You know, we can be a mess, right? So help them out. Tell people. Tell them it's okay. You know, the biggest gift I always tell family and friends that when they say, what can I do to support them, is to say, and I say to them, let them know it's okay to have the space to take care of themselves. They don't have to come to the baby shower for the sister-in-law, you know, whatever it, you know, it might be. And that boundaries are okay, you know, that it's okay to say, you know, what's really helpful to me right now is just taking a time off. You don't need to ask me how I'm doing, what's happening with our treatment, and I will let you know when it's good for me to talk again. Or, you know, and I will tell my most famous, I mean, I got into the field because my husband and I knew we were going to have fertility problems before we even got married, based on previous medical stuff. And so my mother-in-law, who was my late mother-in-law, who was a wonderful, wonderful woman, helped me out early on because she taught me something at the dinner table one night to say where to put boundaries with her. So we're sitting at the dinner table. I am, you know, a young blushing, I might have been a young blushing bride at that point, who knows, but we're talking about things, and she says, oh, Andrea, by the way, you'll be interested in this. And this is now an entire dining room full of people. She said, our cousins, my cousin's son and his wife, who live in California, they're having fertility problems too. Already I'm like, okay, this is dinner, and now this is a public event. And she says, yeah, his problem is that he can get an erection, but he can't ejaculate. Okay, forks are dropping. People are just going, oh my God. And what are words that you never want to hear out of your mother-in-law's mouth? Words like erection and ejaculation. So, you know, she clearly, lovely, lovely woman, trying to be supportive. I could think in her own way, trying to make this, like lots of people are doing this, total boundary violation. To which, you know, I immediately grabbed my husband after dinner and said we were never sharing anything with her ever again. That one was easy, and that was many decades ago, but still can relive it like it was yesterday. But sometimes, so just want to sort of throw that out. I'll stop for a minute.
No, I was going to say, I actually end up role playing a lot with patients with exactly what to say with the boundary, because then you practice while the iron is cool, right? Because then you don't get into the discussion at the dinner table. And I've actually been the mother-in-law. That's my favorite role to play. And they're them. And so that I've had them say something like, you know, can we take my family building plans off the table when we get to family get-togethers? You know, I'll let you know. Or it makes me feel this way when you this, as well-meaning as you are. Is it okay if we just don't talk about my family building plans now? I'll let you know when I'm ready to talk. Or the uncle, every time we get together, is like, you just need to go away and relax on vacation. Jane and John went away and relaxed on vacation. They did 9 cycles and they came back and were pregnant. It just is, I always tell people assume positive intent, which I think is what you're saying. Everybody's means well, they have a good intention, even if they kind of blow it at the end. But have you like these 3 or 4 things that you know that you can say, because it isn't, you can't, there's a lot of resentment when your boundaries cross, but they don't know what the boundary is. They don't know that they crossed it.
Yeah. No, I agree. And look, I also think particularly with friends and family that are close, what's also helpful is with that assumed good intention to let them know that, because it makes people less defensive. It's
Yeah.
like, I know you're trying to, I know you want to help me, and the best thing you can do to help me is to not bring up, you know, family building plans when we're at the dinner table or whatever it might be. But start so that they don't feel like they're backed into a corner. And even if you're angry, upset, resentful, you know, trying to take that deep breath, putting that to the side with the assumed positive intention, and then being able to message in a way that is most likely going to meet your goal. The immediate goal is, I just want to, like, you know, smack you, which is probably not a good way of handling things verbally or otherwise. So, but as much as that's winning the war, it loses the battle. What's the battle? Getting your needs met, which is either, you know, turning off the questions or the information sharing, that sort of thing.
I've shared this before about how my husband's cousin is a dairy farmer, and how a big family gathering, she tried to make me feel better, and she compared me to her cows. And she said, oh, you've got PCOS. She goes, so many of my cows have got PCOS. She said, just let them run around the field. She said, and the fresh air seems to make it all better. Are you getting enough fresh air? And I think, had I had your words of guidance, I would have used them prior to that family gathering happening. And I wish I'd just started the afternoon by saying, right, I want to talk about anything else but me today. Because trying to have a sort of back ref to her cow comment was very difficult.
I literally have people write a couple of like boundary statements that on an index card and put them in their purse. And you have to practice them, like you said, but I have them index card in the purse. Some of them have one of those little photo albums that you can get for like $3, and they put other pictures in there, and that boundary card is in there. Sometimes it changes. Sometimes it evolves as you evolve. But it also can be your own self-talk, like Dr. Braverman said when we very first started. So I tell people that they need to have empathy towards themselves and change their self-talk, you know, to be something like, I'm going through a hard time right now. So it doesn't feel like an all or nothing. I'm going through a hard time right now. I'll pay attention to what I'm feeling, and I respect myself for whatever, my perseverance, my grit, you know, my organization, whatever it is that you have. But it's in addition to these boundaries with other people, it's also acknowledging where you are, that you are feeling bad, that it's probably not going to be forever. It feels like it's right now. And you're going to pay attention to all the things that you've done and can do that are within your power. Like Dr. Braven was saying, we feel so helpless and powerless, but there are some things that we can do. And there are some qualities that we have that are so strong, but they get weighted differently than these bad things, perceived bad things that are going on. That's the hard part.
I have been finding that, you know, with the pandemic, that we all need to be reminded to be nicer to ourselves. I was, you know, yesterday beating myself up over some project that I had totally let drop and feeling bad about it, and reached out to a friend of mine in Seattle, and she, you know, gave me a texting pep talk. She's like, let's just put this on hold till the fall, because I think we're all a little bit overwhelmed right now, and that's okay. And I think it's the same. I think a lot of infertility patients forget to be nice to themselves. And you do need a village. You should have buddies and friends, and hopefully some family members or somebody or a community, you know, the online community. There's some really wonderful things online, and IVF Babel is one of the most wonderful communities that where you can find support. But we have to also, we have to, I think, remind ourselves to be nice to ourselves. It's so easy to forget. It's obvious, but so easy to forget.
Yes. And I'm just looking through the Q&A, which they're all so good. I don't even know where to start, but let's talk about when either, you have an IVF cycle and you retrieve eggs, but an embryo either isn't made, you had poor fertilization, or an embryo doesn't make it to blastocyst, which is the stage at which an embryo implants, usually day 5, 6, or 7-ish. So Dr. Chen, what are the reasons that we can have eggs removed, but then we don't?
The most typical reason for, like, you know, there's typically embryos are growing in the lab for 5 to 7 days and then either transferred or frozen, or tested and then frozen. And there was a Q&A in here asking about, she had 2 cycles, both didn't develop after, both didn't develop, but also testing was negative. So it was a little bit confusing, but typically on day 3, the development of the embryo reflects the health of the egg, because the egg brings everything to the party and the sperm just brings their DNA. So the egg is super, super large. The sperm is really, really small, because the sperm is a DNA missile, and the egg has not only the DNA, but also has messenger RNA, transfer RNA, ribosomes, proteins, all kinds of organelles to support the embryo through basically the whole first week of life almost. So it's very large and it carries all the supplies. So the development up to day 3 typically is a reflection of egg health. And the sperm genome doesn't get geared up, doesn't start really making proteins that impact development until around day 4 of life, when the embryo becomes a morula, and you see it's all squishy and you can't see the cell border so well, because all the cells are interconnecting with each other and talking to each other and doing things like, okay, you're going to be the head and you're going to be the arm and you're going to be the placenta and I'll be the brain, that kind of stuff. So it's talking and deciding and differentiating. And then you make it to the blastocyst stage around day 5 or 6, and where you have like a cyst inside, which is why it's called a blastocyst, and then a part called the inner cell mass, and then the trophectoderm. So, and that's more of a reflection of the chromosomes of the whole embryo. So typically failure between day 3 and day 5 reflects chromosomal issues, extra or missing chromosomes. But you can have a gorgeous blastocyst and still have a very abnormal karyotype. And so, you know, you can have gorgeous blastocysts that will have a, you know, 1 or 2 or more extra or missing chromosomes or parts of chromosomes, which is why pre-implantation genetic testing can be helpful. So arrest is often genetic. And sometimes it's also bad luck. Like, you know, these are not, it's not like we have 100 embryos from one person. So if you have just a handful of embryos and they arrest, the vast majority of the time, I think the studies show, there's not that many studies, but 60–70% of the time, very likely that the next time you do this, you will have an embryo for transfer.
Dr. Braverman, it feels weird to grieve something that was never there. So either, quote unquote, never there, like either an embryo wasn't created or blastocysts weren't. So how is it possible that I feel like some people can feel like they're grieving something that never even existed, they never saw, they never experienced?
Well, I would go back to the word experienced. I think we do experience it. You know, think about it. If you got a positive first pregnancy test, but then it became negative, does that legitimize what you felt? I think we go back to the fact that emotionally, things start up. You know, for some people, they'll say conception. It was the minute for me emotionally. This all started, and it was a conception for me from the moment either of insemination or embryo transfer. And for those 2 weeks, I took care of myself as if I was nurturing that pregnancy. Whether there was no implantation, whether the embryo implanted but failed to develop, emotionally, it's independent. So I know sometimes people feel like it's not legitimate to feel whatever they feel, including grief. But I think when you begin to look at it that way, it makes sense. Yeah, no, it's a pregnancy loss for many people each time, even though on paper, if you will, that's not what it was. The actual experience was exactly that. And then I think we have to ask ourselves, I mean, it was a little bit like what Dr. Chen was saying, you know, we're so hard on ourselves, and particularly now, it's like, what do I have to do to like allow myself to feel like I've earned my sadness, my grief? And, you know, I always try to tell everybody, you know, it's okay if you, I also respect people who have the opposite. I'm not going there. This is a, you know, I'm taking a scientific approach, you know, and so I'm not going to get myself engaged emotionally. That doesn't make it wrong either. But if you are engaged emotionally, you know, that kindness to yourself of saying, you know, okay, whether I want to or not, this is the way I'm emotionally wired. This is the way this cycle has been for me. And that's why sometimes one cycle will be, you know, we kind of get through and we say, okay, I did all right with that. I was disappointed. And other cycles just actually gut you.
So I'm seeing so many people reaching out in the Q&A, and a lot of them we're not going to get to. And I want to say, Sarah and Tracey, what's the best way? Because I really want everybody not to feel like this is it. I want them to feel like they know you and IVF Babble are there 24/7, and they need to keep reaching out and finding general and specific resources for themselves. So what would you say is the best way to reach out to get support from you guys, either mental or logistical or you know, help with finding a clinic or a doctor or a therapist? What's the best way to reach out to you?
And also where to see the previous webinars, because a lot of those specific questions are in previous webinars. So that if you could address that as well.
We always say to people, drop us an email, or if it's easier, just DM us on Instagram with your question.
Okay.
And you know, we will always then pass that question on to an expert. You know, myself and Tracey, we're not experts. We've just been through fertility treatment, so we only ever give emotional support, as in not professional support, but emotional support. So your question will be directed to the right proper professional. So it's always info@IVF Babble or just a DM. It's that.
And also ask an expert at IVF Babble as well.
Okay, so ask an expert on the ivfbabble.com website, info@ivfbabble.com, or DM on Instagram.
Yes, exactly.
Okay.
DM.
Okay, perfect.
And even though we do get a lot of DMs, we do get through them. So even though you won't be answered immediately, we will get to you, and we will make sure that question is directed to a professional.
Okay, that's wonderful to know. Thank you. Now I can sleep at night.
We'll put those links up tomorrow.
Okay.
Or tonight, actually, on we'll post it on our Facebook page.
So that's the previous webinars. Those links are on the Facebook page to the previous webinars.
Yeah.
Okay.
Tia, go on.
I was just going to say it's worth talking about the expo as well.
Yes.
We've got incredible experts, including the wonderful ones that are here today, who are joining us, and it's on the 18th and 19th of July when it's live, and you can have a chat with experts throughout the day, crossing over UK and US timings. And equally, that same expo will be on demand after that live event for 12 months. But you can access any of the experts at any given time through that expo too.
We'll put a link up as well.
Yeah.
Let's go to, just because I want to talk a little bit about the miscarriage and pregnancy loss. And I'm sorry we're not getting to all the questions on all the pages. But I think a lot of us are happy to have a part 2 of this as well. So Dr. Chen, can you address these first 2 questions? So why does a miscarriage happen when we know we don't always know? And could a woman do anything to prevent a miscarriage in most cases? And you're on mute. And by the way, every day on January 2nd, I get a call that somebody tied one on either December 31st or January 1st, and they drank too much, and that's the one time they were pregnant. And so I think there's a lot of guilt and a lot of blame, everybody in those situations.
Yes, everybody always wonders if they caused it. And I think it's very, very hard to cause your own miscarriage. You have to really, really try very, very hard. And most of the time you would fail because if it's a good pregnancy, you know, usually it will stick. We do want you to avoid alcohol. We do want you to avoid hot tubs. If you have a fever, you should, you know, call your doctor, get your temperature down with Tylenol.
No vaping, no smoking.
Yeah, no vaping, smoking, things like that. So it's a lot of obvious stuff, you know, snorting cocaine, crystal meth, it's all out. But it is hard, still hard to cause your own miscarriage. And the vast majority of the time, it's kind of Mother Nature's way of preventing a birth defect, because the vast majority of the time, the pregnancy is actually not normal, not at all normal, and could not make a healthy baby. And ending in the first trimester, often from a medical perspective or Mother Nature's perspective, might be actually the best thing because of the abnormalities. And usually that, again, is reflective of the embryo and not of the parents. The toughest thing we deal with, though, is that people are, more and more women are conceiving in their 40s, because that's the best time to conceive. You know, after you've had your education, you're established, you find a good partner, somebody that you, or you decide that it's the right time in your life to conceive, whether you have a partner or not. And we are really wrestling with this as a human race, because this is happening all over the world. We're having a declining birth rate because Mother Nature designed us to have children when we are much, much younger. And it just does not make societal sense right now. So we are seeing a lot of people struggling with just age-related infertility. So I do want everybody to be proactive. I think if you're thinking about, if you're not pregnant yet, you know, haven't finished your family and you're 35, I think it's good to get a checkup, good to talk to a specialist and just be proactive. Think about freezing your eggs or addressing other issues, like, for instance, polycystic ovarian syndrome, which you guys mentioned, and endometriosis. Both, you know, going on birth control pills in your 20s and early 30s can kind of set you up for less risks, less issues, less complications than for when you are ready to get pregnant. So it's just, I think it is good to be proactive. I don't want to be alarmist, but it's good to be proactive. I forgot what question I'm answering. Monica, did I answer the question?
Yes. Well, what about, so, and the other thing is we're talking about mostly first trimester miscarriage. There's a little bit of a difference if we're getting into later miscarriage, but in terms of first trimester, which seems like most of the questions are, what about if it happens more than twice?
So if it happens more than twice, you definitely need to see a specialist like myself or Dr. James Nikopoulos, somebody who has a reproductive medicine specialty and will do a full evaluation. Now, big warning, the full evaluation often does not yield very concrete results, but often can get you to a point where, okay, well, your sugar's a little bit off, your vitamin D3 level is a bit off, your thyroid is a bit off, your prolactin is a little bit off, maybe you have some anemia. All those things will help optimize your health, decrease your chance of miscarriage. The vast majority of the time, people come back normal on this testing, and their prognosis for the third pregnancy is often very, very good. And they just need a little extra monitoring. Sometimes it's reasonable, especially if you're over 35, especially if you're over 40, to consider being more aggressive and thinking about something like in vitro fertilization with pre-implantation genetic testing, IVF with PGT or PGS or PGD, whatever you want to call it, where we test the embryos for chromosomal abnormalities, because as you get older, and we talked about this in the last video, there's a lot of good stuff in the last video about, you know, it just increases. Extra missing chromosomes are the #1 cause for first trimester miscarriage. And you definitely need an evaluation after 2 miscarriages, but usually the evaluation comes back fine. And most of those people do have a very good prognosis for success, but often need treatment and help.
And so the other thing I want to address, because it came up in a couple of questions that were just emailed to me. So let's talk about this last question, which is resentment for other people who seem to either have no difficulty getting pregnant, or we just feel like it's all around us. We're just at an age where everybody's either celebrating a pregnancy, getting pregnant. Now there's the reveal or whatever of the gender reveal parties, or they show pictures of their kids going to different at different ages, going to different grades, and that gets posted. And so what I want to say, what I tell people to do, and then I want to get Dr. Braverman's opinion on this, is one of the things that's so easy to do with this is I tell people to Marie Kondo their news feed, so and their social media accounts. So go to every single person you follow and say to yourself, does this person or this account bring me joy? Does this person or this account make me feel good about myself or less?
I love that.
Yeah, I do it to my people, to my clients who are trying to lose weight too.
I'm going to do that today.
Yes, it is very freeing. I've got to say, like, I have done it, but it can be also if you're struggling with your weight as well, which I know is not what this talk is about, but there's people on there that look a certain way, and it's very difficult to not compare ourselves to others in both appearances and accomplishments, which for some people infertility feels, like you're lacking in terms of an accomplishment, if you want to put it in such, kind of silly terms. But what you want to do is have an account. This is so easy for you to do. Now you can do it on almost every social media account and no one knowing that you block them, or you pause them, or you mute them, and it doesn't show up. And it's nothing personal. It's basically all about you. This is a boundary. This is like, I want to see things that come through my feed that bring me joy and make me feel good about myself, not the opposite. And I've got to say that suddenly when people do this, suddenly their feeds are a happy place. They are a place where they feel that other people are like them and not that they are the outlier, or they're flawed, or they're lacking or less than in some way. And so this is one of the easy things to do in addition to setting the boundaries, with your relatives, some of the ones that we talked about before. But Dr. Braverman, what about like our friends and family that we love, but they just seem to get pregnant easier than we do? And for us right now, we feel too fragile or vulnerable and unable to really protect ourselves when they're either talking about or expressing, being pregnant, having their baby, all the stuff that goes along with it. And we feel resentful. So we feel bad about them, and then we feel bad about ourselves for feeling that way.
Yeah, no, I think that's the big one. Then we beat ourselves up for the way we feel. And I always just try to remind everybody, start with the premise that feelings are never right or wrong. They're just not. We feel the way we do. How we handle the feelings, what we do with the feelings, is where we can be right or wrong. So if you are so, jealous and angry with that somebody got pregnant and you didn't, that's actually a pretty normative reaction for most people. If you go and you punch that person in the nose, that's probably not the best way to handle the feelings. So the first place is to start with a little self-compassion and understanding. Understand why why these feelings exist. It's okay to say, I don't like having these feelings, but this is where I am right now. And just being able to have that understanding, it leads to, I think, a little more self-compassion. Now, the next thing is saying, realistically, what can I do about this? So I love your suggestion, Monica, about, just asking yourself the question, does this bring me joy? Am I keeping this person in my feed because for some reason it's like it feels good to keep pressing the bruise to a certain extent that I think some people will talk about, but is that really back to serving? What's my goal? My goal is to keep myself as strong as possible, and to keep myself understanding I'm not all the negative things I'm telling myself. If it's people that you can't avoid, if you're at a family function and somebody's pregnant there and it's going to be tough, also understand, is it something you have to take a hard pass at? If it's the holidays and there's a big family event and it's just all the conversation, no matter what anybody says, is going to be about the pregnancy, then do you and your partner, or do you just need to say, maybe this isn't the year that I attend? And that may be hard because you feel cut off and alone. But, if we are not quarantined, then maybe it's creating something and going someplace that does bring you joy. It would be better to be with my family and doing all of this over the holidays, but you know, maybe this is the year, not forever, but this year it's better to do this. And then finally, you know, being able to know your audience. If it is somebody that you can speak with, of just speak your heart. I love you dearly. I'm so happy for you that you're having a baby right now. It's super difficult for me to be around it because right now it's hard to keep to not feel like this is never going to happen for me. People can relate to that. And so trying to let them get into your shoes and being able to describe it in a way that they can hear it is a wonderful thing to attempt, or at least practice.
You have to practice saying these things though in advance, even if you're role playing, because I'm telling you, when you're sitting there and the heat is on, it's very difficult to do. So it almost has to be like you just pick a couple of I typed a whole bunch in the chat of things that I've told people to say that sometimes, but we have a couple other things in the chat, like you're the only female, you know, in the family. So everyone's kind of waiting and they either asking or nice asking, you're the only child. And so then you carry the burden now of, you know, disappointing your parents. Obviously it's not intentional, but that's another thing. Somebody wrote in the chat, I like to put my social media apps into a folder and label it think to remind me to think if I'm having a strong day or not, and I could deal with what might appear on my news feed. And so I think this is the other ways of controlling these little things that Dr. Braven said in the very beginning that we can control. You know, reducing clutter, making things organized. Those little things give us a feeling of empowerment when we feel like there's a lot of areas in our life where we don't have them. We only have time for a couple more questions, but Dr. Chen, a couple of emails just got sent to me. So how many IVF cycles are too many and how old is too old? And I know these are easy questions to answer. You're on mute.
Okay, so IVF cycles, you know, you can do a lot of IVF cycles and sometimes it does take a lot. Very large study from the UK, actually, a few years ago that said, even if you failed 5 or 6 previous egg retrievals, your pregnancy rate for the 6th retrieval still significantly high. So that reflects, I think, the fact that Mother Nature is extremely inefficient. It is a numbers game. The more embryos we transfer one at a time, the higher the overall pregnancy rate. And the more times you try, the better chance you have ultimately of having a baby. Now, that does not mean there's no line in the sand. That's a very individual decision. And you need to, you know, be open with your doctor about having that conversation, be open to hearing that. But multiple cycles is perfectly reasonable. And that's really hard because just going through one IVF cycle often feels like a marathon in and of itself and a long, long journey. And for people to think, oh my God, it might take 3 or 4 egg retrievals, that's really hard. I think you got to take it one step at a time. But, you know, we're not sure that we have a limit. I like to say on an individual level, I like to assess, is there going to be some benefit from another cycle and not much risk. So you're still doing that whole risk benefit ratio. If it favors, if the risk is low enough and the benefit outweighs the risk, then reasonable to move forward. Donor egg, in the donor egg industry in the United States, they do like to have a lifetime limit on egg donors for 6 cycles, but that's kind of arbitrary, and there's no evidence that the number of cycles in itself is necessarily harmful, depending upon your circumstances. What was the second question, Monica?
Is how old is too old?
How old is too old? So
this is with their own eggs. It was somebody was
own eggs. Everybody has different cutoffs, but it does seem we get close to 0 on our pregnancy rates around 43, 44 years old for the vast majority of the time. We have tried with patients older than that, but you are looking at very, very low pregnancy rates in over 43, 44.
And then Dr. Braven, I have 2 more really easy questions for you.
Boy.
which you know are never that way.
Yep.
So one is, how does the couple, assuming it's not a financial reason, know when they're done, when enough is enough, when how can they come to terms with that? And is it just the most important thing that the couple agrees with each other? Or, you know, how do they know, like, we are ready to refinance our house, we're ready to go into debt, to do one more cycle? How do we know when enough's enough? Do they go with their gut, or is there a problem solving kind of algorithm or some kind of thought process that you have about that?
Yeah, I mean, there is no algorithm to come up with that, and I do think it has to be a shared decision, but that doesn't mean that it's not a negotiated decision. So the when is enough is sort of, I think, you know, weighing how the benefits and the costs, and some of that may be if you are taking out another mortgage or a loan, that what that is a literal cost, but it's also the emotional cost too. I think that looking at that expectations for the cycle is, you know, many people will say it's easier to keep going than it is to stop. I know, I become familiar. It's my way of life. It's a purpose. I have no idea what my life looks like if I stop. And so I think that is part of the process, which is to say, you know, can I stop and imagine what life would be like if we're not continuing to do cycle after cycle? Am I doing the cycle to avoid asking that question? Am I doing the cycle because my doctor and I share the same vision that this is still, I still have a good chance at achieving a pregnancy and a healthy delivery? So I think that although there is no algorithm for when's enough, I think we do all share some of the questions to help get us there. You know, what is the end goal? When I see people coming in that are planning to adopt, to use donor or a surrogate, it's partly because they've said, you know, particularly when it's a non-genetic child, it's like, at this point, I want to be a parent more than I want to be a genetic parent. And so I can say enough to one, but not enough. Yeah, but that doesn't mean I'm saying is enough to everything. And so I think we just keep asking ourselves the questions and not just automatically, doing the same thing over again, and just trying to not think.
And last question, which is sort of a segue into this. So couples have decided to stop, and they, or a person, individual, and they do not have a living child out of the experience. Do you know, or do you have any thoughts for maybe either from your experience or other couples, or if somebody wants to write in the chat things that might be helpful for that couple, or things that have helped couples in the past with that? Is that related to what you just said, or are there any additional thoughts?
I think it's adding on to what I was just saying. First of all, there are a lot of support groups, not a lot. There are support groups, there are Facebook groups, there are communities for people who have chosen to move on without a child. And, you know, the term, everybody uses different terms. I think that you do not see childless anymore, because I think that less is, I think, experienced as pejorative. But I think that if you're choosing to live child-free, which is the most often used term in the US, that is also not a terrific term either. I'm not particularly enamored of it. So, you know, what is the vision? You know, language is important too. Am I choosing to go on and ask without a child in our lives, which then begs the most important question, which is, how do I live a full and meaningful life? We have to ask that question of ourselves, whether we put children in our lives through whatever means, or do not. So you can't say, okay, I'm going to stop and I just think everything's going to work out okay. It's like, okay, what are you going to go on and do? Early on, I had a couple where, you know, the woman was doing a job that she didn't, you know, was fine. I mean, it made a living and she wasn't unhappy in it, but making the decision to not have children allowed her to change to change professions and do something where she felt, well, if I'm not going to, in the US, putting your kid through school is very expensive in college. She's like, if I don't have to save for college, well, then maybe I don't need to frame my work life. I will have a family around me who have children. Can I connect with nieces and nephews or be a godparent in some way? Is that meaningful for me, or is that not the route that I'm going? Maybe it's not centered around children, but it is doing something else. So I think that it is so important to not just to make a decision and think it all sorts itself out. I think it's so important to then answer that question to ourselves, because on the hard days, on the dark days, on the challenging days, we understand how and what we're going forward.
Thank you.
And I've got this comment here. There's this, I won't say her name, but she's basically someone who has, we've been in touch with ever since we launched IVF Babel, and she's been through rounds and rounds of IVF, and we've always communicated, and she has just come to the decision that her fertility journey is now over. And she's literally just in her post, she actually commented in our miscarriage post the other day, and she says here, she said, I've just found that it's important to focus on all the good things in my life, the things I've been blessed with, and the things that I'm so thankful for. So if anyone is, I know you must seek professional guidance, but if anyone wanted to, through us, connect with, is that it?
No, I don't know what happened. Oh,
we're still recording, but
yes,
I'm just
sorry. Yeah.
If anyone wanted to connect with this brilliant girl, then if they want to send us a direct message, we can connect them with her, because just talking to her and understanding how she came to that, I think would also be very comforting.
I love that idea. I think it is very, very helpful to hear other people who have really gone through it and come out on the other side.
Yeah.
Don't be alone.
Yeah.
Exactly.
No. And what's the question, Dr. Braven? I think we should end on that everybody said something about meaningful. What's the one question we should kind of ask ourselves?
How am I going to live a meaningful and rich life?
Yeah.
And I wrote down something you said, Andrea. What is my goal? To keep myself as strong as possible.
Mm-hmm.
And I wrote down Marie Kondo, your social media feed.
Yes. So I put all of our, including Dr. Nicopolis's ways to reach us in terms of email. Dr. Chen and I, it's best to go to our Instagram and DM us, but you can go to websites as well. For anyone asking about self-care stuff, we do have a self-care talk that we did, and I have a lot of that I'm going to do in the expo, and I have a handout for that as well that I can give to Sarah and Tracy. If you're not able to make that, you can at least have the handouts. We got some questions on sleep, alcohol consumption, exercise that we were unable to answer today, but I'm happy to either do that or send that information to you. So thank you, everyone. Thank you for all of, this has been one of our most interactive and really touching and talks. So we feel very grateful that
so
you
wonderful that so many people reached out with their stories and questions.
Yeah, thank you for being vulnerable. We're so grateful, and we never take that for granted. So we really appreciate that. And so we'll have this recording and probably a couple business days. And
don't lose touch. Like this is the IVF Babel platform is such a great place to gather.
And we do this every Wednesday at 5 p.m. UK time, unless you hear otherwise from us. So you can just kind of look and expect all the changes as a topic, but we're pretty much
12 p.m. East Coast, New Jersey time.
New Jersey time. So thank you so much, everybody.
Thank you.
Sending so much love.
Thank you.
Thank you. Great to see everybody. Thank you.